Chapter 2: Interprofessional Collaboration and Care Coordination. Introduction. The state of healthcare in the U.S. is dynamic and very complex. For a patient to safely, effectively navigate through a healthcare system requires coordination among all members of the ICT. However, access to care that is coordinated, safe, and focused on the patient's needs across all healthcare settings have eluded many patients, including older adults and people with chronic illnesses. The Institute of Medicine, IOM, is now the National Academy of Medicine, has released 2 landmark reports that address the quality and fragmentation of healthcare throughout the U.S. These documents recommend the necessary transformations in healthcare needed to provide safe, effective, patient-centered, effective, timely, and equitable care. Nursing practice, which has historically been setting-defined rather than patient-centered, is part of this transformation. Care must be integrated and coordinated across settings, particularly for patients with chronic diseases who experience frequent changes in health status and require multiple transitions among providers and settings. Vulnerable patients are put at a greater risk during transitions if care is not coordinated, communication among professionals is inadequate, socioeconomic factors are inadequately addressed, and the needs of the patient and caregivers are not taken into consideration. Care coordination and management patient transitions across care settings is integral parts of nursing care and an expanding role for the RN. Med-surg nursing quality and safety competencies and targeted knowledge, skills, and attitudes are necessary to prepare the RN to lead care management strategies and traditional care services across the care continuum. Overview of transitional care. Transitions refer to the time period when the patient is moving between levels of care and care settings, such as discharging home from an acute hospitalization. The safety of the patient is at risk during these transitions because issues may arise and adverse events may occur, causing preventable hospital readmissions and increasing costs. The patient's needs may go unmet, and there's a risk for med errors and adverse clinical events. 2/3 of post-discharge adverse events are related to medications. The readmission rate of hospitalized patients, particularly Medicare beneficiaries, is one driving factor in the call for improved transitional care services. Nearly 1 out of 5 Medicare patients discharged from a hospital is readmitted within 30 days. Of these readmissions, 76% may be preventable. These rates are often attributed to a lack of coordination of care as patients are discharged to rehab facilities, to long-term care agencies, or back home. Without a plan to ensure continuous and coordinated care, these patients may be readmitted with complications. RN involvement in the transition of care process, particularly for patients with complex needs, is key to ensuring the patient is prepared and ready to safely return home. Although hospital readmissions may not be related to the most recent hospitalization, insurance companies and other payers consider unplanned admissions as wasteful spending and, in some cases, may deny reimbursement or may charge penalties for readmissions within the 30-day window after discharge. Data trending the numbers of unplanned readmissions after a recent hospital stay are used to measure the quality of hospital care. Focusing on more efficient and effective transitional practices and models should decrease the incidence of unplanned readmissions. Transitional care features a comprehensive assessment of the patient's health goals and preferences, evidence-based plan of care, engagement of patients and caregivers in planning and implementing the plan of care, and interdisciplinary communication. The transition of care process involves medication reconciliation and post-discharge follow-up visits and calls. The implementation of evidence-based practice to guide post-discharge calls is an example of how readmission rates can be lowered with care coordination. Increasing access, improving quality and safety, and lowering costs are the basic principles of the Patient Protection and Affordable Care Act, ACA, that was signed in 2010. Transitional care programs have demonstrated that with the prevention of affordable readmissions, patient safety and quality of care improves and costs are lower. For these reasons, transitional care is a high priority in the Act. The Community-Based Care Transitions Program, Centers for Medicare and Medicaid Services, Innovation, Health Homes, and the Medicare Shared Savings Program all support transitional services. Additionally, nursing care during transitions is intended to ensure healthcare continuity and eliminate the risks associated with care that is fragmented. Transitional care programs are patient-centered and typically manage the transitions of patients from acute care to post-care settings. The goals are to avoid poor health outcomes, ensure continuity of care, and facilitate safe transitions between care settings. Unlike disease management and case management programs that are ongoing, transitional care is time-limited. Emphasis on coordinating care, facilitating patient engagement and education, addressing the causes of poor outcomes, and avoiding preventable readmissions, focusing on the 30-day time period following discharge. A meaningful transition plan will include addressing those socioeconomic factors that affect the health of the individual. To support vulnerable patients and address these socioeconomic issues, the transitional care nurse will use a spectrum of community resources and programs. There are many organizations, websites, and providers who specifically address the immediate needs of these patients out of the hospital and home in their communities. These resources answer questions, provide necessary medical equipment, and suggest community support groups of people who are dealing with similar disorders or issues. Important strategies in managing the transition from acute care to post-acute care settings include the following: involving the patient caregiver and/or surrogate in healthcare decisions and care planning, respecting the patient's values, preferences, and expressed needs, initiating care coordination/transition planning at least 24 hours before discharge, organizing post-discharge follow-up services for patients requiring chronic disease management, providing specific discharge teaching related to symptoms requiring immediate treatment, coordinating with care providers responsible for management in discharge settings, and providing a comprehensive medication review. Evidence-based models of transitional care. Several models of transitional care have emerged in response to the call for improved coordination across the care continuum. The Transitional Care Model, TCM, the Care Transitions Program, Project Red, and Project Boost. Another transitional care plan is the Patient-Centered Medical Home, PCMH, a model for comprehensive patient-centered care, primary care. A model that focuses on quality and safety in the hospital, transforming care at the bedside, TCAB, was developed as an important first step in ensuring safe transitions across the continuum. Furthermore, in the past several years, healthcare systems and hospitals have initiated care management programs that address the unique needs of their patient population and community. The Transitional Care Model. The Transitional Care Model, TCM, is an advanced practice RN coordinated team-based approach to caring for older adults with chronic illnesses developed by Mary Naylor, an advanced practice nurse at the University of Pennsylvania. The Transitional Care Nurse, TCN, manages patients as they transition across the care continuum from inpatient settings to other settings. Using evidence-based coordination systems, the TCN collaborates with other healthcare team members, including providers, nurses, social workers, and pharmacists to plan care. The goal of this model is to prevent any complications, provide continuity of care, and increase patients' and caregivers' abilities to manage their care. The TCM focuses on chronically ill, high-risk adults. Common medical and surgical conditions often included in this model are heart failure, diabetes mellitus, chronic kidney disease, and post-surgical hip surgery. Because many of these patients have multiple comorbidities, coordination of care is critical to safe, quality care. The TCN engages with the patient and caregiver to identify the patient's values, preferences, and needs, and develops an advanced care plan that describes the patient's goal of care. In this model, the TCN visits the patient in the hospital and following discharge, visits the patients weekly at home for 1 month. The TCN then conducts follow-up phone calls during the second month. The patient is followed for approximately 8 weeks or until goals of care are met. Specific TCN tasks include monitoring symptoms, care coordination, and teaching and coaching self-management skills and medication management. Results from National Institute of Health studies and a recent 2022 multi-site replication randomized control trial demonstrate that the TCM significantly improves patient safety and healthcare outcomes. enhances the quality of life and satisfaction with care, and reduces overall healthcare costs. This model has demonstrated long-term outcomes by having the same advanced practice nurse provide care across settings. The TCN can be an advanced practice nurse or a bachelor's level nurse. The typical caseload for most TCNs is 15 to 20 patients. The role of care coordinator or TCN is expected to grow as reimbursement is linked with decreasing administrations to acute care settings and cost-effective care management. Incorporating the competencies of a medical surgical nurse with those of a care manager and patient advocate, this role requires knowledge of evidence-based care, working in interprofessional teams, quality improvement, and financial issues related to care delivery across multiple episodes of care. The Care Transitions Program, developed by Eric Coleman at the University of Colorado Health Sciences Center, the Care Transitions Program employs nurses as transition coaches to manage chronically or seriously ill patients as they transition between healthcare settings. The transitions coach does not provide direct skilled care, but rather uses effective communication to provide education and guidance to ensure a safe transition. In studies using a coaching approach, it has been demonstrated that patients who received education, encouragement, and coaching had lower rehospitalization rates. In the Coleman model, transition coaches visit the patient in the hospital and follow up with one home visit and phone calls for a 4-week time period. Patients receive tools to learn self-management skills that include recognizing and responding to red flags that indicate worsening of their condition, managing medications, managing their own personal health record, and completing follow-up care with their primary provider. Project RED and Project Boost. Project RED and Project Boost are national programs that also seek to improve care as patients transition from acute care settings to post-acute care settings by improving the discharge processes. The objectives of Project Boost, led by the Society of Hospital Medicine, is to identify patients at risk for readmission on admission, reduce 30-day readmission rates, decrease length of stay, and improve communication of patient care information during discharge. A risk assessment tool developed by Project Boost helps to identify patients at risk for adverse events after discharge. Called the 8P scale, this tool is completed on admission and identifies risk factors such as polypharmacy, problem medications, physiological issues, poor health literacy, principal diagnosis, patient support, prior hospitalizations, and palliative care. The 8P scale is used by the ICT to determine appropriate discharge needs. Project RED is a research group based at Boston University Medical Center that develops and tests strategies that improve hospital discharge processes. The RED is based on 12 interrelated components that promote patient safety and reduce readmissions. The 12 components are as follows. Ascertain need for and obtain language assistance, make appointments for follow-up medical appointments and post-discharge tests/labs, plan for the follow-up of results from lab tests and studies that are pending at discharge, organize post-discharge outpatient services and medical equipment, identify the correct medicines and a plan for the patient to obtain and take them, reconcile the discharge plan with national guidelines, develop and teach a written discharge plan the patient can understand, educate the patient about their diagnosis, assess the degree of the patient's understandings of the diagnosis and discharge plan, review with the patient what to do if a problem arises, expedite the transmission of the discharge summary to clinicians accepting care of the patient, provide telephone reinforcement of the discharge plan. Both Project RED and Boost offer tools, the 8P scale and the comprehensive discharge instruction tool that aid the ICT in safely and appropriately planning for the patient's discharge. These tools also complement the strategies of the TCM and patient transition program. Patient-centered medical home/guided care program. Also included in the Affordable Care Act are programs and initiatives focusing on the patient-centered medical home, PCMH. An enhanced model of primary care, the PCMH engages ICTs to address and care for patients with multiple comorbidities. Specifically, the PCMH promotes care that is patient care-centered, comprehensive, interprofessionally coordinated, and accessible on a long-term basis. The guided care program is an example of PCMH that has improved patient outcomes and quality and reduced costs through nursing interventions. Guided care nurses work closely with the interprofessional team to coordinate care for the patient with a chronic illness. They assist in coordinating with the transition between sites providing care, assess the patient and caregiver in their home, create an evidence-based care plan, promote self-management, and facilitate access to community resources. The guided care nurses work with the patient on a long-term basis. Transforming care at the bedside model. The Transforming Care at the Bedside (TCAB) project was implemented in 2003 to address the recommendations related to improving the quality and safety of patient care on med-surg units. Specific aims of this program also address the importance of retention of nurses at the bedside, participation of patients and family in their care experiences, and interprofessional team effectiveness. The training has been embraced by hospitals and healthcare systems to create a culture of safety and strengthen the role of the bedside nurse in improving quality care. Adding validity, the effectiveness of the program was demonstrated in a 2013 study. The TCAB model focuses on the following themes: safe and reliable care, vitality and teamwork, patient-centered care, value-added processes, and transformational leadership. In this project, frontline nurses and staff work on the development and implementation of action plans to address the overall quality and safety of care. Full participation of patients and families is integral to the project. The priorities of TCAB include transformative change and continuous learning and discovery as changes in practice are implemented and evaluated. Hospitals participating in the initial 2 phases of this model reported fewer codes, decreased patient injuries secondary to falls, lower readmin rates, reduced nurse turnover, and an increase in the time RN spent in direct patient care activities and overall staff satisfaction. TCAB is currently in its 3rd phase, being implemented in 78 hospitals. The development of rapid response teams also grew as a result of TCAB efforts. These teams in acute care settings are composed of clinicians who provide critical care expertise at the patient's bedside or point of care, and typically include a critical care provider or intensivist, critical care RN, pharmacist, and respiratory therapist. They respond when a patient shows signs of deterioration in an effort to recognize and reverse the problem before a cardiac arrest occurs. Patient education, an essential component of IC and all care models, striving for effective in-hospital and transitional care is patient education. Patient teaching can be conducted in any setting by any member of the team. It is essential that the patient demonstrates an understanding of the diagnosis and plan of care in order to safely transition to home and avoid readmission. Teach-back is an effective teaching strategy used to enhance patient education. The nurse as patient care coordinator. The RN providing direct care to patients is directly involved in the coordination and management of care in the acute care setting. Because of the increasing complexity of healthcare and growing numbers of patients requiring chronic care management, the role of the RN as a patient care coordinator is evolving in acute care, rehab, long-term care, and home care settings. Because patients are frequently discharged from acute care settings, still in need of follow-up and nursing care, home health nursing is a growing practice area for acute care and med-surg nurses. The American Academy of Ambulatory Care Nursing developed the Care Coordination and Transition Management (CCTM) model to standardize the practice of ambulatory nurses as well as acute, subacute, and home health nurses in care coordination and transition management roles. The CCTM is grounded in care management and chronic disease management. The RN and care coordination and transition management roles practices across the care continuum, applying appropriate evidence-based interventions that focus on patient safety and quality of care during care transitions. To facilitate continuative care across the care continuum, the RN must use interprofessional collaboration and coordinate healthcare services and community resources. The CCTM model provides a core curriculum, interventions, or competencies necessary for the RN to be successful in care coordination and transition management roles. Expected knowledge, skills, and attitudes are identified for each dimension, which include advocacy, support for self-management, education, and engagement of patient and family, cross-setting communication and transition, coaching and counseling of patients and families, nursing process, teamwork and collaboration, patient-centered care planning, and population health management. Developing the knowledge, skills, and attitudes needed for each dimension will help the RN meet the needs of patients and families with complex chronic illnesses and healthcare needs. Interprofessional collaboration. Interprofessional collaboration, IC, occurs when two or more professionals work together to solve problems or coordinate care. The concept that the whole is more than the sum of its parts is particularly meaningful when looking at the value of IC. IC is a partnership between a team of healthcare professionals and a patient and in a participatory and coordinated approach to shared decision-making and communication. An important component is the inclusion of the patient and family in care and transition planning. This coordinated effort is ideally done in an atmosphere of mutual respect and shared responsibility for outcomes of care. When the interprofessional care team, ICT, convenes, each individual's professional training and knowledge are used to optimize the patient's health outcomes. Team members are confident in their knowledge of each other's roles and how they contribute to the patient's care, can activate the team when needed, and hold each other accountable. The purpose is to formulate and deliver a plan of care that is goal-oriented and team-focused. Goal-directed care focuses on the overall aim for each patient. Daily care objectives remain focused on that overall goal, facilitating the efficient use of time and resources. The evolving changes in healthcare financing and reimbursement are creating new imperatives for interprofessional teamwork. While coordinated collaboration, allowing effective and cost-effective care, is not only good but is also essential in meeting contemporary healthcare financial challenges. As an example, a study that explored collaboration between the nurse and pharmacist when reconciling medications at admission and discharge found that preventing one discrepancy in every 290 patients encounters one would set off the cost of intervention. These findings demonstrate that investing in ICT collaboration may be effective and cost-effective way to ensure safe care. Furthermore, in a recent meta-analysis of randomized controlled trials, the role of the nurse as a leader is emerging. Nurse-led transition to care interventions is decreasing readmin rate risks and reducing length of stay, two critical cost of care metrics. The RN can contribute much to advancing the patient's goal via the ICT from a variety of settings, including inpatient, long-term care, and the community. Interprofessional communication. Team members convene in a variety of ways with the purpose of providing a form of team communication. This forum provides the opportunity to listen to other team members' assessments and recommendations, provide specific input, and make collaborative decisions. The ICT may convene in a regularly scheduled structure, such as daily rounds, or on an as-needed basis for highly complex patients or for patients who experience frequent readmissions. In a hospital setting, multiple disciplinary rounds, MDRs, may be conducted on nursing units. The goal is to discuss each patient with all ICT members present in order to develop a comprehensive plan of care for both in-hospital and transitional care. This is done in an effort to improve hospital care, reduce unnecessary hospital days, and prevent readmissions. Rounds may be in a walking format where the group moves from patient to patient. This format facilitates the timely inclusion of the patient in the care planning process. This is optimal to the process of patient-centered care. However, the lengths of rounds can be significant. Rounds conducted away from the bedside in a conference room can be structured to ensure maximum efficiency. The discussion should be limited to 2 to 5 minutes per patient. On a typical nursing unit, this results in rounds lasting about 1 hour. Included content is designed to cover daily care planning and discharge needs and includes a discussion of the following: brief overview of the clinical situation, the overall medical plan for the day, a risk screen that indicates a potential need for post-acute needs and complex discharge planning, care involvement as applicable, patient engagement, teaching needs and health literacy, a discussion by each discipline that addresses the plan to prepare the patient for a safe transfer to home, planned discharge date, specific actions that need to be completed in order for the discharge to occur, and a discussion of required documentation for discharge or transfer. It's also important to recognize when planning care for patients during rounds are social determinants of health. Social determinants of health, SDOH, are conditions in which people are born, grow, live, work, and age. During MDRs, the team may discuss SDOH as they affect discharge planning, resources, and health inequities. Examples include literacy, housing, food, availability, and safety in the home. As discussed, the ideal is to have all team members present for the discussion, but that's not always possible. At these times, the team member facilitating the discussion may need to consult the missing ICT member before or after rounds to provide or receive a patient update or seek information about patient plans. SBAR is an effective communication technique used to facilitate concise and accurate communication between members of the team. It is especially useful when attempting to convey a message to a team member not present during rounds. In addition to using SBAR as the format, it is equally important to ensure that the ICT members communicate in the electronic health record, EHR, especially during transitions in care, and addressing SDOH for vulnerable populations. Interprofessional education. Future generations of ICTs are being shaped, and interprofessional education, IPE, is a part of that development. IPE is necessary for effective IC. It is defined as two or more disciplines learning how they work together in a hospital setting and outpatient settings. In the setting of IC, IPE is focused on each discipline, understanding its respective skills, roles, and scope of practice. In doing so, each member can best engage the others appropriately for their expertise in patient care and together provide well-coordinated care. As an example, it is important that the inpatient team understands home-based services and available community services. This helps to ensure that all factors necessary to include in the transition of care is to improve safety are there. This process results in greater efficiency and confidence in managing the discharge process. There is increasing recognition that IEP holds promise for preparing health professionals as collaborative-ready practitioners. Students who participate in an introductory IPE course early in their professional preparation develop and maintain positive attitudes towards IC and learning. Furthermore, research suggests that teams who understand each other's roles better facilitate team-based interventions that improve care for a patient at discharge. It is important that the RN understands each team member's roles, when to request input, and how to offer input into the patient care plan. The RN should become knowledgeable about all members of the team and should educate the team as to the nursing role in each patient care setting. The nurse should also take responsibility, along with other members of the team, for the education of the patient as to the members of the ICT and their roles. Patients and family can easily become confused on whom to consult for specific questions. If they lack confidence or are hesitant, they may not clarify critically important care needs. Members of the ICT use their respective areas of expertise to educate patients, explain indications for contacting the provider, and coordinate post-hospital care, including provider appointments and home care. As noted previously, patient participation in the ICT is essential to ensure that the patient's goals and preferences are integrated into the plan. Composition and roles of the interprofessional care team. In the healthcare setting, a group of professionals work directly or indirectly with patients to help them return to optimal health. Each professional has unique training and addresses a particular aspect of patient care. Together, these healthcare professionals form the ICT and contribute to the development and implementation of a plan of care for the patient throughout the continuum of care. The ICT typically consists of, but is not limited to, the professional discussed in the following subsections. Registered nurse. The RN is a professional who utilizes the nursing process to care for the patient, to assess, plan, implement, and evaluate. The RN performs the patient assessment and formulates the appropriate NANDA diagnosis. The plan of care is formulated on the basis of assessment and nursing diagnosis. The plan is implemented and evaluated. Provisions are made on the basis of the evaluation. Because of the 24/7 around-the-clock responsibility for the RNs, they are the eyes and ears of the healthcare team members. The RN provides feedback to the provider on the efficacy of medical interventions and reports normal and abnormal objective or subjective assessment findings. Most important, the RN is the patient advocate, intervening on the patient's behalf to ensure appropriate care and providing patient teaching to facilitate positive outcomes after discharge, including handoffs to other levels of care. The RN may practice in a various amount of settings, including home care, ambulatory care, long-term care, and many other areas. The RN may also function in a charge nurse role. In that role, the nurse focuses on broadening from a specific patient assignment to the nursing unit as a whole. This focus includes staffing, patient movement such as discharge, transfer, admins, and oversight and support of all staff on the nursing unit, such as new nurses, LPNs, LVNs, and UAPs. The LPN role functions under the direction of and delegation by the nurse. The list is not comprehensive, but as an example, LPNs can provide direct patient care that includes helping with ADLs, such as bathing, toileting, and feeding. They can also obtain vital signs or lab specimens, complete wound care or dressing changes, and administer some meds. Unlike the RN, they do not have the same level of authority or responsibility and cannot make independent decisions. Unlicensed assistive personnel, UAPs, is a grouping of paraprofessionals who play a critical role in maintaining safe and accessible care. These paraprofessionals are responsible for the completion of patient care tasks, such as getting vital signs and assisting patients with ADLs. They must receive appropriate training and demonstrate competence before assuming new or expanded responsibilities within these settings. Delegating and monitoring of the UAP is defined in policy under the Nurse Practice Act. The UAP is accountable to and it works under the supervision of the RN when performing a delegated patient care activity and requires ongoing monitoring. With all patient care roles, it's important that communication during the planning and provision of care is maintained to ensure safe and effective care. Delegation. Specifics regarding the 5 rights of delegation are included in Table 2.1. It is important for team members to understand the authority of the RN and the delegatee's scope of practice as it relates to patient care. It's also important to understand the rules within each specific setting because the rules may vary from institution to institution. Providers. Physician. The physician, MD or DO, is the healthcare professional who, after reviewing the history and physical examination and results from labs and radiology findings, makes a diagnosis and plans for medical care. The physician typically leads the ICT with input from the entire team. Mid-level practitioner or advanced practice providers may also provide leadership of the team under the direction of the physician. These include certified registered nurse practitioners and physician assistants. Growth of these roles extending into the home setting is occurring as a result of the state of emergency during the COVID pandemic. Certified registered nurse practitioner. Working with and under the direction of the physicians, CRNPs can diagnose and manage most common and many chronic illnesses. They perform physical exams, order, interpret diagnostic tests, provide counseling and education, and write prescriptions. The CRNP role in discharge planning varies by institution, but when involved, this role assists with the attending physician in assessing the patient's post-acute care needs, coordinating necessary referrals, ordering important follow-up services, and most importantly, conveying this information to the family and patient. The CRNP may attend rounds between the ICT and attending, which is particularly useful for surgeons who may be unavailable when in the operating room. The CRNPs may also assist in completing required transition documents, such as those required by specific insurers to order to qualify for care, written orders needed at the next level of care, and discharge instruction forms. A transition call may be placed by the community physician, apprising this physician of the inpatient care experience and post-discharge plan. The CRNP is typically available for post-discharge calls and possibly for clinic visits. Of note, the CRNP may be able to assist with making recommendations for specific nursing care as well. Physician assistant. Similar to the NP, PAs may obtain medical histories, perform exams and procedures, prescribe medications and treatments, order and interpret diagnostic tests, diagnose on the basis of those assessments and tests, and assist in the operating room. They typically work with specific physicians, may attend rounds on behalf of the attending, and may also assist with the discharge planning and transition care plan as described previously for the NP. Social workers. The social workers are professionals who assess the psychosocial functioning of patients and families. They intervene as necessary, PRN, connecting patients and families to necessary supports and resources in the community. They can also provide supportive counseling and help patients strengthen their network of social supports. The SW assists with specific transition care planning, such as guardianship for patients who cannot make sound decisions. Rehabilitation therapy. Physical therapist. The PT is the professional who assesses and provides training and education on physical strength, gait, and mobility for the patient. This professional may also provide wound care and teach transfer techniques, secretion clearance techniques, and neuromuscular re-education. The PT evaluates and assists patients in utilizing techniques to maximize their safety during and after the hospitalization. Occupational therapist. The OT is the professional who assesses and retrains the patient to perform ADLs, such as bathing or brushing their teeth. This professional utilizes adaptive equipment to assist patients in performing these activities, such as a grabber. The OT also provides visual and spatial perceptual training, such as using a double vision eye patch, as well as energy conserving for patients with poor endurance, such as chronic respiratory conditions. Speech-language pathologist. The SLP is the professional who assesses, diagnoses, and treats patients with disorders relating to speech, language, swallowing, voice, and cognitive communication. The SLP develops specific exercises and recommends food consistencies for patients with aphasia and a tracheostomy to help prevent complications. The respiratory therapist. The RT is the professional who specializes in airway management. As part of and in collaboration with the healthcare team, the RT is responsible for maintaining the airway through the administration of oxygen, nebulized medications, and assessment of the respiratory status and lung function. The RT cares for patients with all types of respiratory disorders and lower lung disorders. The RT is able to perform arterial blood gases, ABGs, to monitor oxygenation, ventilation, and acid-base balance. Registered dietitian and nutritionist. The RD is the professional who assesses the patient's nutritional needs, develops meal plans, and provides education about dietary modifications related to the individual's disease process. The RD promotes healthy eating habits and assists patients in adapting to acceptable diets. The RD also assists in designing enteral and parenteral plans for patients who can no longer eat by mouth and require gastrostomy tubes and central line nutrition. Case manager. The CM may come from a variety of backgrounds, typically an RN with an advanced nursing degree or a social worker. This member utilizes the processes of assessing, planning, facilitating, advocating, and providing available resources to meet the individual's health needs with sound quality and cost-effective outcomes in mind. The CM incorporates the input of the ICT to plan in-hospital care and transitional discharge care. This professional monitors services to ensure that the patient has available resources to return to their optimal health. This may include conferring with the provider to make a hospice referral or assisting the patient in securing medications. Transition guide. The TG, typically an RN with an advanced practice degree, assists patients during and after transitions with the goals of ensuring a smooth transition, identifying and managing readmission risks, and assisting with aligning possible resources to aid in the patient's plan of care. The TG may meet with the patient before discharge and reconnect by phone or home visits, and is typically accessed by Other home-based services. The implementation of TG services is an effective intervention for the hardest to reach patients who may be at the highest risk for readmission. The pharmacist is actively involved in management of the patient's medications, including the following: reconciliating the patient's meds between transition of care, reviewing orders for appropriateness and adjustment to the hospital formulary, monitoring for medication interactions or adverse medication reactions, monitoring for therapeutic levels, providing medication counseling to the patient and family members, and providing patient education on new or complex medications. The pharmacist oversees pharmacy techs who assume responsibility for pairing medications. Pharmacists are important ICT members because of their skills in identifying the best medication regimens for the patient. That include factors such as costs and caregiver skills. Ad hoc members of the ICT may include one or more of the following: chaplain, community health worker, palliative care coordinator, substance abuse counselor. The interpreter is the professional who facilitates the understanding of medical information by translating the information into English to the patient's native tongue and vice versa. Specific competencies are required in order to interpret in the healthcare system. Family members should not be relied on as an interpreter because they may not accurately impart all the information the patient needs to hear and understand. The chaplain is the professional who has an educational background in religion. They provide spiritual comfort to patients and family members in need. The community healthcare worker is an emerging role in healthcare. CHWs serve as a port of connection between the patient's community and the rest of the healthcare system. They may address single health issues or multiple chronic health issues, and they have differences in their level of knowledge, training, and practice settings. Palliative care coordinator is an advanced practice RN who provides information and support for the family and patients when the patient needs disease, pain, or symptom management, or is in need of hospice care when the patient has a terminal illness. This professional facilitates end-of-life decisions with the patient, family, and healthcare team members and helps coordinate the care at home or an inpatient facility. Discharge planning must begin the day of admission, especially with short lengths of stay. Key to that is determining the details about the patient's social network, such as the following: are their family members or friends available to help upon discharge? Does the patient have a home to return to, or can they return home? Can the patient afford the medications ordered? Chapter summary. The need for better patient care coordination, particularly smoother transition of care between different care facilities, is a growing concern in the U.S. healthcare system. Increased medical errors, often resulting in patient harm, increased lengths of stay in hospital settings, and increased healthcare costs are all driving factors for better care coordination. Patient-centered transitional care and other care management initiatives are within the nursing scope of practice. Transitional care models and patient-centered medical homes put nurses in leadership positions to help coordinate care. Nurses in these positions easily transition with the patient and become a link to care. The TCM, Care Transitions Program, and Guided Care are evidence-based practices that utilize nurses in providing patient-centered care coordination across the care continuum. The IC is an equal partnership among varied healthcare professionals and the patient, all working together to provide care to patients. While in the hospital, patients receive care from the IC. When preparing for discharge, the role of the IC is to prepare the transition care to the patient and family. The essential components of this collaboration are coordination, communication, and shared responsibility. The purpose is to formulate and deliver a plan of care that is goal-oriented and team-focused. Goal-directed care focuses on the overall aim for the patient. Daily care objectives remain focused on that overall goal. Members of the team include the RN, physician, social worker, PT, OT, respiratory therapist, nutritionist, care management, pharmacist, and speech-language pathologists. Other members of the team include an interpreter, chaplain, home care coordinator, palliative care coordinator, and substance abuse counselor. The ICT may round and review patient care or speak informally, but often uses a standardized communication such as SBAR. Interprofessional collaboration improves the care of the patient by increasing coordination between all healthcare disciplines. Time and resources are utilized more effectively. Discharge issues are identified early. Interprofessional collaboration enhances the professional satisfaction of the members of the healthcare team. Ultimately, the outcomes of IC include improved communication, enhanced safety, decreased costs of care, prevention of unnecessary readmins, and positive care outcomes. The patient benefits from care delivered by an interprofessional approach, and the practice of the nurse is enhanced.